All right, well, let's get started. So, hey everyone, this is John Hansbrough with the LBL Group. We're here with Sam Walters today from Roundstone, Roundstone Insurance, and we're here today because kind of like every video in this series, what the kind of interviews that we're having, we're trying to talk about the dysfunctions that are going on in today's healthcare system, and then from our side, what are things that we can be doing? So, if it's the people we're talking with, what resources are out there to address those dysfunctions? What opportunities are in the market where we can address the incentive systems, the different players in the market? What can we do on data and transparency? Because we're all trying to push for improving the healthcare system, right? The same stats that we'll talk about time and time again. Healthcare in America is a $3.7 trillion industry. There's about 30% of that is estimated to be waste, right? Our outcomes are some of the worst in the entire world in terms of developed nations. I think we rank like 37th. Yet we're spending the most, and not even just the most, but like by far and away the most on our healthcare. So there's such a complete disconnect between what we're spending and what we're getting in healthcare outcomes. And I think, I'm obviously biased. Sam, you're on the same boat with us because of what position that we play in the industry. But I think a lot of that responsibility, that opportunity for that change comes down to the payers and the people working with those payers, which is our role as consultants. Sam, how are you doing today?
I'm doing well. Can't complain. It's a beautiful day here in Cleveland, Ohio, and really appreciate this, John. Also appreciate the partnership with you and the LBL Group and Acrisure, but doing great. And like I said, really appreciate this, and hopefully I can bring a little bit of knowledge what the captive market can bring.
Yeah, totally. And so from you guys' role, I guess, we talked about this a little bit ahead of time before we started broadcasting, but healthcare, we know there's a lot of things that need to get addressed. There's a lot of opportunity for us from consulting to the payer side of the system, right? There's the delivery system. We're more focused on that finance system because so much is going to come down to what's going on with how things are getting paid for. And that's just going to drive so much behavior in the healthcare market. What about that gets you up in the morning, gets you, I know right now we're not going to work, but gets you up, opens up the laptop, gets you working? What is it about the opportunities right now in the healthcare market that gets you excited and gets you working?
I just like what gets me up is just seeing the actual results of what we are able to deliver to the market. So, it starts with data. We had talked a little bit earlier. You can be a 150 life group with Kaiser in California, or even a 250, 300 life group. You get zero data. So it all starts with data. It's a top 3 line item expense. No other expense for any healthcare or any other companies going up in a 10 to 15% clip every year. So it starts with the data, then it starts with the plan, and then how you can manage it long term. So we want to focus on the long term, but that's what gets me up is when we come up to a renewal and we have these things called a 2020 report. It's not an industry term, but you can kind of show your savings of where you were in a snapshot. So those will be coming out soon as we get towards our renewal season for our January groups. And, when I see those, it's always a nice positive.
Yeah. Well, and you're right on the data because, and again, we chatted a little bit about this. I was talking about this last week with my friend Levi because he's working on consulting to the actual healthcare delivery system side of the business. And with the lack of data that's out there, data informs so much of how business decisions are made today. Right? We're never usually shooting from the hip. We're usually saying, based on trend, based on what's going on, here's what we're going to be doing moving forward. And then based on whatever strategy or implementation is made, we're looking at the data to figure out how that's working, right? And if that's not working, we're going to iterate and change things a little bit, and we're going to keep tweaking things and moving forward. And it's why you see progress in like the television market, right? Plasma TVs come out, then, HD TVs, and now 1080p and 4K and all that. And the entire time, that cost of the unit is going down, right? Even though the quality is going up. And so we're not seeing that a lot of times with healthcare. In fact, the healthcare costs are always increasing, even as outcomes are either staying constant or going down, right?
Exactly. And you got to look at it in inflation too. So workers' wages, they've been up minimally over the last 10 years. So let's say you give your employee a 10%, 15% merit raise, but then your insurance renewal comes out and it's 25%. And then what are you going to do? Either shop, or you're going to make that deductible from $1,000 to $500, Or the employer might say, you know what, we don't know of any other options because my broker didn't bring any other options, and you've got to pass on that increase to them. I mean,
Mhm.
so it kind of negates that, oh, nice field guy, I got 10% more, but oh, wait, my insurance just negated that because I'm up 20%. I'm actually down.
Mhm.
So we talk a lot about managing, not chasing rate. Manage your per employee per year, and you
Mhm.
can't really do that unless you're in a self-funded plan.
Right. And that's like where a lot of that stuff starts, right? Because, and we make this comparison because like within our network, we have a lot of partners who do things like workers' compensation, other kinds of property and casualty insurances. And there, just to get a quote, I think you were saying this, right? You need 5 years of loss reports.
Mm-hmm.
You need that to get a quote, right? And then if
Yep.
you do have a bad year, you're getting hit with, an XMOD rating, right? They're increasing the rate based on what your actual experience was. And if you're the leadership at a company and your workers' compensation costs are going up that much, you're putting into place all these different interventions, right? And I kind of wonder if that's the reason that there's a difference between how that market works versus health insurance, where you've got these CFOs who, they're paying so much attention to the workers' compensation costs, but the healthcare costs go up by the same amount. And
Yep.
there's a complete disconnect in how they're reacting to it. Do you think that probably has something to do with just how complex the healthcare system is versus what might be going on in workers' compensation? Is it a little bit easier to get someone's head wrapped around how the workers' compensation costs are being driven?
Yeah, I mean, it's definitely. I mean, the workers' compensation obviously is driven by the mods, but what I like to look at is, I mean, you're a manufacturer, and yeah, I mean, there could be some dangerous stuff, depending on what you're manufacturing, but you have probably a risk manager that handles that. All right. What you can do with a self-funded plan and a captive is you can put a risk management, kind of how you do on your workers' comp and your PNC, the benefits, but without the data, you really can't do that. So
Mm-hmm.
data analytics, we partner with a company called Deerwalk, so you get data analytics with us. And I mean, that's going to be, okay, I've got 20 claimants that are diabetic. Might not have known that. Let's put together a plan for that. Or you may have had someone, some claimants, you have 20 claimants, let's say, go to the emergency room, which is ridiculously expensive. All right. When you kind of look at it and, you could have actually gone to an urgent care, or you could have done telemedicine, which is huge now. So, I
Mm-hmm.
mean, these are all things that you can help manage. But another thing you want to help manage is the RX spend. I mean, the RX spend is out of control right now. Watch TV. It's drugs and cars. We're the only country, I think, that we actually go to our doctor and say, I need to be on that.
Mm-hmm.
So in the 1990s, your RX spend was roughly 5%. It's now 25%, 20 to 25%. I've got some groups. I have one group in Colorado, 90% RX, 10% medical. It's
Wow.
absolutely ridiculous.
Yeah.
So
I mean, it makes sense. Like you're watching TV and you see you see some truck commercial for a truck that's selling for $60,000, and then the next ad is an ad for Humira. It's because they're selling it for a ton of money. They're not selling it for five. You're not getting that generic Claritin ad, which I
yep.
take Claritin, Flonase. I have some allergies, right?
Mm-hmm.
They're not marketing, in the Super Bowl.
No.
That's a different market, right?
Yeah.
And so when you talk about data, when you talk about transparency, I think one of those end results you want from getting access to them, because getting them is great, but the next step is chronic disease management. But a big thing, right, that we're always struggling with in healthcare is how to help people be active consumers of healthcare. Because if one of your employees, again, going back to the television example, goes to Best Buy down the street, they want to buy a television, but it's maybe, $200 more than what they could have found online. They're just going to, on their phone, on the way back to the car, they're going to buy that TV online and have it shipped to them directly, right? But
Mm-hmm.
we're not doing that again with healthcare. What are things out there trying to help people be more active consumers of healthcare? How is the data helping them do that?
Well, are you familiar with any like the concierge apps?
Some of them, yes. Yeah, like Heal.
So yeah, so Heal. There's HealthJoy. There's Compass out there. I mean, these are great tools. Like for example, like last year, my manager he was getting a knee replacement. All
Mm-hmm.
right, and we're in Cleveland, as I mentioned. So all he does is pick up his app, his Compass app, and types in knee surgery. All right. Well, three different places came up. Metro Hospital, the Cleveland Clinic, and University Hospitals. They ranged between $22,000 and $50,000. So he ended up going to the Cleveland Clinic, all right, which they were about $22,000, all right, which, and there's nothing wrong with going to the Cleveland Clinic, but getting to a point here. So he goes and gets his knee surgery. He gets his first bill, $49,000, all right. He has insurance and everything.
Yeah.
So what he did was he was just able to take a picture of the bill. 2 days later, that bill was down at $22,000. And, you know, after his deductibles and copays, it cost him about, you know, $1,500 or something. So
Yeah.
these are tools too that you can see, you know, what's the best drug, you know, it's going to be mail order or, I mean, pretty much anything you're looking up, you know, like, do the virtual visits. You know, I do those with my doctor now. They're great.
Mm-hmm.
But going back to one thing, you know, wellness is great and everything, but nobody needs to be told, you know, smoking, eating Big Macs. Everyone knows that's bad, all right?
Right.
No company needs to pay $10 per employee per month to know that. So we're big believers in getting a biometric screening. So get a biometric screening, find out what's wrong with you. I mean, when you go to your normal doctor, I think it's maybe a 19-point step, but I mean, there's ones that have 49 points, and you know they're going to pinpoint what is actually going on. But a lot of employees are not going, you know, they're not going to do this unless you dangle a carrot. So if you might say, you know, if you take this, you're going to save $50 a month. So you know, these are some of the things that you can use the tools that are out there.
Got it. Yeah. Well, and I know that I think you've shared the story with us before, but could you share with everyone what's the background on what kind of, I guess, prompted Roundstone to be started and what got you guys started on your journey?
Great. So Roundstone, so we were founded in 2003 by a guy named Mike Schroeder. He's still our president CEO. We're a privately held company. So he had actually worked on the PNC side for a company based in the Akron area that did captives, and they perfected captives for school buses, trucking, anything wheels based. And he was their chief operating officer. I mean, he was their general counsel. So he knew how captives work, knew the function, knew how to deal with the regulators, you know, whether they're set up in Bermuda or a different, you know, North Dakota or something. So he kind of went to them and was like, hey, why don't we do this on the benefit side? And they're kind of like, you know what? We stick to our guns. We're PNC. We're growing. And then, you know, like any entrepreneur, he started Roundstone in 2003. And I mean, it was a slow going. You know, it was just him and built it up. And then started getting a lot more traction in 2005, 2006. And then something big in 2010 happened, which is the ACA. But before that, he was kind of a street evangelist going around saying, buy into my product. And, you know, ironically, we actually started in California, which was some of our first captives in the nursing industry, I believe up in the northern area. But we built up, you know, we have well over 500 plus clients, over 40 different captives. We're also a managing general underwriter for nationwide insurance. And Roundstone just means it's a town in Ireland. That's what we're named after. But, you know, Mike's still very, very involved in the company. And, you know, he's committed to our growth. And we're about 80 employees now. When I started, I think we had about 20. We've made the Inc. 5000 the last 3 years in a row. You know, we're always on the list of top places to work in Northeastern Ohio. But my background kind of came from it. Like I've been on the PNC side.
Right.
I worked for the brokerages, like a big brokerage, like USI I worked for. Then I went to go work for on the PNC side, but then I actually went to go work captives for the company that Mike was at. And kind of just met someone by chance and said, hey, have you heard of Roundstone? I'm like, I drive by there all the time, but you know, you got to meet this guy. And so somehow we met. But when I first started being a property and casualty guy, you have to have 5 years of loss runs for your workers' comp, your auto liability. And I was under this belief, like, everyone gets claims data. So like, I'm out to dinner with my dad. My dad's like, how's the new job? And I'm like, oh, they're giving insurance quotes without 5 years of loss runs. My dad sells advertising, you know? So he's like, well, that sounds shady. And I'm like he knew what he was talking about, you know?
Right.
And then like, I was just so flabbergasted that you could be 150, 100 life enrolled group, you get zero data. And then they kind of had to sit me in the corner like, crazy man. This is why we do what we do.
Right.
We practice transparency, cost savings, and long term. So, but I mean, that was just an eye opener for me. So, I mean, you theoretically could be, you're a 100 life company in Southern California with Kaiser. You may have only had $300,000 in claims. They just pocketed let's say you're spending $1 million. They just pocketed $700,000 off of you and want to give you a 5 to 6% increase.
Right. Yeah.
Or even more.
I was going to say, it's interesting that your all's growth pattern has really tracked, I think, generally with the market, right? What is it? And these are approximate numbers, so don't quote me on these. You'd have to look these up. But I think the most recent study that I've seen has the total number of employees in America covered under self-funded plans at about 60%, right? And then because usually it's going to be larger companies, about 40% of US companies, maybe a little bit less than that, are self-funded to some degree. Whether that's using captives, using stop loss insurance, or just flying by the seat of their pants. That I think has been, and that trend has really been consistently increasing for the last 15 to 20 years, right? And that just blew right through the ACA. It's just been this steady increase. And so a lot of that has to be, obviously 80% or more of companies over 1,000 employees are self-funded. But it's that 100 and 999 market where I think a lot of that growth probably has that increased uptake, that increased adoption of self-funding has been going on because, just like you said, they're getting these rate increases. Maybe they're in a pooled renewal or what have you, and they've got limited levers they can pull to address costs, and they've got limited data to even understand what's going on, right? And, I guess if you're, what is it? Let's say you're making cookie dough, right? Or you're making cookies and you're selling those. If the cost of one of your inputs, say chocolate chips or flour or milk or eggs, was going up, you would look into so many different ways about how to address that, right? But companies never really think about the fact that they have a healthcare side business and they're in the healthcare supply chain and they don't think about it.
Yeah, and just to add on to that, I mean, I think it's 90% or something like that. But these companies that are large, they don't self-fund because they can. They self-fund because it works, and it's the most efficient way to manage your healthcare spend. What's nice about the captive is captive just means pool, co-op, cooperative. Long story short is we're banding companies together to reduce the cost of their medical spend. It's that simple. We're giving you that rate of a Fortune 500 company by banding together with the strength. I mean, our captive pools have roughly 40,000 enrolled lives or covered belly buttons in them. So these are a pretty large spread of risk, but my lowest group actually is 14 enrolled, that's doing a self-funded plan with us. And, they're running great. We typically play in that 50 to 1,000 market. And the majority of our business is coming from fully insured or a level funded. But one thing I also wanted to back up when you're talking about, brokers, so there's a difference between a broker and an advisor. And that's why I like working with your firm. All right. A broker just comes to you every year and says, here's your 10 to 15% increase. What do you want me to do? Do you want me to shop it? Because it doesn't really matter to them if they're getting a 15% increase, they're getting another 15% increase on their commission. So the broker just shows you this spreadsheet. The spreadsheet only looks 12 months out. All right. 12 months out. All right. You're not fixing anything besides all you're doing is on that hamster wheel. You're just spinning and spinning around. So we like to work with you guys, what we call an advisor. An advisor is going to take a look at what your really needs are and set you up for the future. So we're an employer-based model. We don't pay commissions. We don't pay commissions. You guys pick, as you guys know, you pick your own fee in our program, but we're not paying overrides like the big boys do or anything like that. So we like to work with an advisor that's actually going to have your best interest and needs to help manage your program.
Right. Yeah. One, what one of our other acquisition partners, Seth Denson, said, he said, if you solve the economics of healthcare, you can solve healthcare. And so when we talk about economics, one of the key elements of economics are incentives. And so in healthcare, then there becomes that question, where is the alignment of incentives? And, we see that with health insurance companies, right? They've got MLR rates, and that for a number of reasons incentivizes them to just consistently keep raising premiums, right? And with health insurance brokers, that's always an issue that we're seeing, is that if our compensation is tied to how much you're paying in premiums, and a company's best interest is to pay less in claims, those are completely disconnected. And so it's needing to try to reconnect those to put the broker on the side of the table with the client and not the side of the table with the insurance carrier. And insurance can be good, right? I've had that. I've had small groups where I've had a group that was like 5 people. And one of the founders of this company, it was a small tech company here in Santa Monica. His wife has a kid. The kid goes into the NICU for a month. That doesn't work for them if they're self-funded. That's why they're 5 employees. They're on one of the bukas.
Yep.
That worked perfectly for them. They're a startup company. And another element of theirs was they don't know if they're going to be around in 5 or 10 years, right? And it ended up being they weren't. I think we did one total renewal with them. They were in business for about 18 to 20 months. They're a perfect candidate for health insurance. There's obviously business reasons why you would use insurance or not use insurance. And I always think it makes sense to caveat, you're still using insurance of self-funding. It's just a different model, right? You're actually insuring the extreme losses, whereas
Exactly.
health insurance is usually more of a credit card, right? That's usually,
and that's kind of where the stop loss comes into play with us too.
Right.
Is we cap those catastrophic exposures through stop loss. So, and our stop loss starts at 500K. So any member in the captive, a claim that hits over $500,000, that's going to the reinsurers.
Right. Yeah. So, talking about cost containment, companies are getting this data, they're looking at their costs, they're finally getting an idea of what's going on. The next step is cost containment. What are some things that companies can be aware of, strategies they can take to better manage those costs that they're actually incurring once they start paying for those directly?
Yeah, I mean, it all depends. Obviously, it's going to start with the data. Do you have an RX? Did you have an RX problem? All right. Are you on Humira, Stellara? There's companies out there that they're called patient advocacy, RX advocacy. They can help amend your plan document. We just saved a group that we renewed for 7/1. Super high RX spend, but we were able to shave off $250,000 of their RX spend. That's what they don't have to worry about next year. We were able to do that. But there's also other vendors out there like End Stage Renal. That's a $250,000 a year claim. There's companies you can carve that claim out called Renalogic, Dialysis PPO. But what our team's doing is so we have something called the CSI team. So we got very creative. They're called the cost savings investigators. They're a second set of eyes on these large claims that are managing to say, okay, something strange is happening here. Something strange is happening here. Or I have a recommendation. Like it could be like, hey, like I said before, we were looking at your data analytics. Like you went to the emergency room 20 times, but if you put you with a concierge app or something like that, you could have just gone to urgent care or done telemedicine to get that down. Yeah. But it all starts with, what is the claim, and what can we do to help manage that? So right now I'm actually going through pretty much, this is a nightmare situation. For the insured it's an infusion and it's 800% over Medicare. 800%.
Wow.
$45,000 a month of what's going on. So we're doing everything we can, at the renewal here to get that down. We've actually had ideas. We actually had plans where we can move the claimant to a different facility. They don't want to go, and we understand that can get a little touchy, but these are things that we're gonna have to deal with. I mean, 800% over Medicare is just absolutely ridiculous. Yeah. And the provider's getting away with it. And, one of the big boys, the term BUCAs, which Blues, United, Cigna, Aetna, and Anthem, the one that we start with an A is not really helping us get that claim down. So, right. But yeah, our cost containment team is going to come in and say, okay, we're going to recommend X, Y, and Z, and next year we're going to get this down. Right.
Well, and I think that comes into that delves into also taking advantage of centers of excellence, right? CAEs, saying, you can choose which providers you want to go to, but instead of putting all the providers on the same tier and making you pay, like, for us here in Southern California, Cedars, UCLA, maybe Memorial Care if you're down south, like instead of choosing amongst all of those equally, even though the actual cost of that care might be totally different and the outcomes for those procedures might be totally different, putting those putting those providers on a tiered network, right? And saying, these ones have the best outcomes. And so we're going to make you pay the least amount possible as the consumer to go there. But if you want to go to this other facility because your father's roommate is the doctor there and you really want him to do your procedure, they're not as good on outcomes. And so to go there, you're going to have to incur more of that cost. Those are center of excellence kind of opportunities. What have you guys been seeing in taking advantage of those and implementing those with groups?
Yeah, no, I mean, we're big believers in the center of excellence. We've got a really good center of excellence here in Cleveland with the Cleveland Clinic, but obviously we got to see exactly what the claimant is. That's where the CSI team is going to come in, and there's over 175 cost containment vendors that we deal with, and then we're gonna basically take a look like, okay, we literally have 3 or 4 people on the CSI team that is going to say, okay, it's going to depend on where, what the claim is, and then see what we can do to work with the Center of Excellence to make sure they have the best outcome.
Mm-hmm. Got it. Yeah. And have you been seeing, is there any kind of innovation going on in that space? I mean, you mentioned 175 different cost containment vendors. You all are probably getting bombarded by new entrants into that space. And I know that's, something that I've been seeing in the healthcare space. There's just, startups get into the healthcare space. They don't know what they don't know. And then they kind of narrow down and say, all right, self-funded groups are where I'm going to, right? Mm-hmm. And then trying to solve this very narrow sliver of an issue for self-funded groups. Are you guys constantly seeing new entrants into the space trying to solve?
Yeah. We do get bombarded. I could probably get bombarded probably once, maybe, at least once a week. I got an email yesterday for a new PBM, but I mean, we're going to listen to them. Like I said, we exist to take dollars out of this, corrupt health insurance system. So our CSI team is going to, I'm going to set them up with them, see what it calls. And we have a committee. We have a committee that gets together, I think, once a month, and we'll look at our cost containment vendors and say, you know what, here's a new one. And then we either say yay, nay, or neutral. Neutral being, hey, we think it's great, but we don't promote. I mean, we give recommendations, but we don't come out and say use X, Y, and Z or anything like that, because we don't take kickbacks or anything like that. But if we think that it's a good product, and your client wants to use it, then we're totally okay with that. But yeah, we do get bombarded, and but we are going to vet them, and we're going to vet them, pretty hard too, because we want to make sure they got their ducks in a row. And we found some great partners out there, like the RX advocacy companies that I was mentioning. I mean, those have done phenomenal jobs.
Yeah, that's awesome. So, before we're starting to get close to wrapping up, so if you have any questions, drop them in the chat box. We'll make sure we address them before we go. Looking forward, Sam, what's coming down the pipe for you guys? Anything that's particularly exciting that you got your eyes on the calendar for, or just kind of same old business and just adapting to the COVID life?
So no, I mean, business has been booming. So what's actually nice is we're going to have a press release here shortly. This is huge. So we're giving back, and I think in our January captives, we're giving back $10 million of premium back to the clients. All right. And I don't know what the average group is going to get, but I mean, let's say, I think last time the average group got back $63,000. I mean, this is just icing on the cake. This isn't their claims. This is just for being part of the captive pool and why you join it. So we'll have a nice press release. We're going to have a lot of happy January clients, but we're gearing up to this renewal season. The best part about being self-funded right now, it's a cash flow bonanza for these companies. Mm-hmm. Our companies nobody's going to the doctor. There's no elective surgeries. I just got a call from one of my groups in San Diego, and my advisor calls up and she's like, hey, they've got $800,000 in reserves. What should they do with it? I'm like, well, it's their money, and do they need to keep funding, $100,000 a month or whatever it is? I'm like, no, they can stop that. They can go pay as you go. That's a nice reserve. So we're hearing a lot of success stories about that. And it's literally, I mean, it's, you're not spending it right now. So So that's huge. I mean, we're looking forward to this renewal season. And, I mean, we've been growing at about a 20-30% clip, and I think we'll definitely surpass that again. And then renewals, I think we hit about 95% for July. I mean, that's huge.
Yeah.
So right now, cash flow bonanza for these companies, and they're thinking long term.
Yeah. Well, and we talked about that a few weeks ago with Josh Axing. He's an actuary. And we were talking about that. What amount of care has been deferred? And then what amount of care has just been not occurring, right? So like the example is dental care, right? You're not going to go get 2 cleanings in 1 week. You're just missing that one. That one is evaporating. It's never happening again.
Yep.
If you need a knee or back surgery, you're deferring that until you're able to get it. And it seems like from what the analysis that he's seeing, there's a lot of care that's just going to disappear. And so there's going to be, like you said, that in this month, we're now on 5 months of this, 5 months where claims were either significantly down or just somewhat down. And that's just savings and cash flow back to all these groups. Whereas our fully insured groups, sure, they're not having the, administrative work they're having to do, but they've been paying their premiums every single month. Nothing different there, and we're still anticipating that we're going to go take to them some kind of, renewal for their benefits. And it's just this game that they're still playing that we're always trying to educate them on. And is it working for everyone, or is it ideal for everyone? Maybe not, but it's better to know what's out there and to make an active decision around it. And I think that's the biggest thing with you guys is let's just talk about it, present it, show it to groups, let them make an active decision, right?
Exactly. We want it to be the right fit for them too. And, I mean, we probably turn down 25% that come through the door because we want to keep the captive healthy too.
Right.
But, we do believe we have like-minded employers that get together and, to reduce that cost, that medical spend, and that's what the captive does.
That's awesome. Yeah. What would be, Sam, what's the best way for people to get in touch with you if they've got any questions?
They can email me, or my cell phone, obviously, I'm not in the office very much, but, or, obviously get in touch through you, would be great.
Yep. Awesome. All right. Well, thanks everyone for joining. Have a good rest of your day, and we'll talk to you soon.
Great. Thanks again.
Yeah. Thanks, Sam. Bye.